Have you ever wondered what medications doctors themselves refuse to take, even though millions of people swallow them every single day? The truth is, some of the most commonly prescribed or over-the-counter drugs come with risks most people never hear about. And surprisingly, many doctors, when it comes to their own health, won't go near them. Today, we're going to reveal 5 medications that doctors avoid, yet are quietly recommended to patients just like you. If you're over 60, pay extra attention. These choices could directly affect your longevity, cognitive clarity, and quality of life. Let's explore what the experts know that you might not. Proton pump inhibitors, PPIs, the hidden gut destroyer. They're advertised as miracle solutions for heartburn, acid reflux, and indigestion. Medications like omeprazole, esomeprazole, and lansoprazole. Collectively known as proton pump inhibitors or PPIs, they've become a staple in medicine cabinets across the world, especially among seniors. But what many people don't know is that despite their popularity, many physicians refuse to use them for themselves unless absolutely necessary. Why? Because beneath their soothing promises lies a series of health concerns that unfold silently over time, ones that could affect your bones, brain, kidneys, and immune system. PPIs work by blocking the enzyme in the wall of the stomach that produces acid. This helps reduce symptoms of GERD or ulcers. However, this acid isn't just a nuisance, it plays a vital role in digestion, nutrient absorption, and protecting against harmful pathogens. When this natural defense is suppressed long-term, the consequences can ripple through the entire body. Several large-scale studies have drawn attention to the dangers of chronic PPI use. For one, reduced stomach acid interferes with the absorption of crucial nutrients like magnesium, calcium, iron, and vitamin B12. This can lead to a cascade of problems particularly harmful to older adults, such as bone thinning, fractures, fatigue, muscle cramps, and even anemia. Doctors know this, and that's why they often find non-pharmaceutical methods or limit the duration when using these drugs themselves. The risk of bone fractures becomes especially concerning for seniors. In fact, the FDA has issued warnings linking long-term PPI use to an increased risk of hip, spine, and wrist fractures, all of which are potentially life-altering for older individuals. Another major concern: the link between PPIs and kidney disease. Research published in journals such as JAMA Internal Medicine has shown that prolonged PPI use is associated with a higher risk of chronic kidney disease and even kidney failure. What's more alarming is that this damage can occur without the classic warning signs. No pain, no discomfort. Just a gradual decline in kidney function over months or years. Many nephrologists and geriatric specialists advise their own family members against using these medications long-term for this very reason. There's also growing evidence connecting PPIs to an increased risk of dementia. While the mechanism isn't fully understood, it's believed that by disrupting the gut-brain axis and contributing to vitamin B12 deficiency, both known risk factors for cognitive decline, PPIs may increase the likelihood of memory loss and neurodegenerative disease. It's no wonder some neurologists avoid them entirely. Infections also become a greater risk. With less acid in the stomach to kill bacteria and pathogens, seniors on PPIs are more likely to suffer from infections like Clostridium difficile, C. difference, which can cause severe diarrhea, dehydration, and hospitalization. Doctors who understand the gut's natural defense system are often wary of dismantling it without a backup plan. That's why, when they do need relief from reflux, they might instead choose lifestyle interventions like elevating the head of the bed, reducing late-night meals, and avoiding trigger foods such as spicy dishes, alcohol, and caffeine. Others may opt for safer short-term alternatives like H2 blockers, medications like ranitidine or famotidine, although even these are not without risks when used long-term. Most importantly, doctors understand the value of using PPIs only when absolutely needed, for example, to heal an ulcer or during a short recovery window, rather than as an indefinite daily maintenance tool. They also take the time to re-evaluate their symptoms periodically, tapering off when possible instead of using the drug indefinitely. This strategy, often ignored in routine patient care, is standard practice among medical professionals who want to minimize their own risk. So if you've been taking a PPI for more than a few weeks or months, it's worth revisiting the conversation with your healthcare provider. Ask about re-evaluating the necessity, exploring alternatives, and even running blood work to check for hidden nutrient deficiencies. After all, it's not just about eliminating discomfort, it's about protecting your future health. Statins, the cholesterol controversy doctors don't talk about. Statins are among the most prescribed drugs in the world, hailed as lifesavers for their ability to lower cholesterol and reduce the risk of heart attacks and strokes. But if they're so effective, why do many doctors quietly sidestep them when it comes to their own health? The answer lies in a growing debate within the medical community, a controversy rarely mentioned in routine consultations but well known among professionals. Statins like atorvastatin, simvastatin, and rosuvastatin work by inhibiting an enzyme in the liver that produces cholesterol. This helps reduce LDL, or bad cholesterol, in the blood. On the surface, that sounds like a universally good thing. However, cholesterol isn't just the villain it's made out to be, it's a vital component in hormone production, cellular structure, and brain function. And that's where the concern begins. Doctors who read the fine print and interpret long-term research often find themselves questioning whether statins are always the right answer, especially for patients without a prior cardiovascular event. One of the biggest reasons many physicians are hesitant to take statins themselves is the significant risk of side effects. Muscle pain, weakness, and fatigue are among the most common complaints, sometimes progressing to a condition called rhabdomyolysis, which is a serious breakdown of muscle tissue that can lead to kidney damage. Seniors are particularly vulnerable to these effects, which can dramatically reduce mobility, independence, and quality of life. Many doctors are also aware of the cognitive effects that have been linked to statin use. Though the data is mixed, there are enough case studies and anecdotal reports to raise red flags, particularly involving memory lapses, brain fog, and confusion. Some studies even suggest a potential link between statins and the onset of type 2 diabetes, another major concern for older adults who may already be struggling with insulin resistance or weight gain. The other controversy: whether statins actually save lives in people who don't already have heart disease. This is known as primary prevention, and it's where the evidence becomes murky. Several large meta-analyses and systematic reviews have shown that while statins may lower cholesterol levels effectively, their impact on overall mortality and serious cardiovascular events in low-risk individuals is modest at best. This leads many doctors to question whether the benefits outweigh the risks for patients who have never had a heart attack or stroke. It's not uncommon for physicians to recommend lifestyle changes as the first line of defense, not just for their patients, but for themselves. Dietary changes like reducing processed sugars and trans fats, increasing omega-3 intake, getting regular exercise, and managing stress are all proven to support cardiovascular health. These strategies are safer, long-term approaches that don't come with the baggage of side effects. Then there's the issue of coenzyme Q10, CoQ10, a nutrient crucial for energy production in our cells. Statins deplete CoQ10, which may contribute to the fatigue and muscle problems many users report. Doctors who do take statins often supplement with CoQ10 to counterbalance this effect, but that's a step many patients are never advised about. Additionally, many physicians are also wary of the psychological effects of statins, not just the physiological ones. The knowledge that you're on a daily medication for the rest of your life can have a subtle but powerful impact on mental health, sometimes creating a false sense of security that undermines healthier choices. Relying on a pill can unintentionally sideline critical lifestyle habits that have an even greater impact on heart health. For these reasons, a growing number of physicians are moving toward a less is more approach with statins, especially when treating themselves or family members. They weigh risk factors like age, blood pressure, family history, and lifestyle before ever writing a prescription, something that isn't always standard practice in rushed clinical settings. Perhaps most importantly, doctors know how to interpret cholesterol numbers in context. A slightly elevated LDL level isn't necessarily cause for panic, especially if HDL, the good cholesterol, is high and triglycerides are in check. They understand that inflammation, insulin resistance, and oxidative stress play equally important roles in heart disease, and that statins don't address those factors at all. This more holistic understanding of cardiovascular risk leads many medical professionals to tread cautiously with statins, reserving them for cases where the potential benefit clearly outweighs the long-term risks. It's not that statins are inherently bad, it's that they're often prescribed reflexively, without the nuanced consideration they deserve. And that's a decision many doctors would never accept for themselves. Sleep aids, the silent saboteurs of brain health. When sleepless nights become the norm, it's understandable that many seniors turn to sleep medications for relief. After all, the promise of drifting off quickly and staying asleep sounds like a miracle to anyone struggling with insomnia. Drugs like zolpidem, commonly known as Ambien, temazepam, and over-the-counter antihistamines such as diphenhydramine, found in Benadryl and some nighttime pain relievers, are routinely used to quiet restless minds. But here's the surprising truth. Many doctors, despite having access to these same medications, avoid them for their own use. The reason is chillingly simple. The risks often outweigh the benefits, particularly when it comes to long-term brain health and day-to-day functioning. Sleep aids don't promote natural sleep, they sedate. And sedation, especially in the aging brain, can have unintended, far-reaching consequences that are rarely discussed during casual doctor visits. First and foremost, sleep medications have been repeatedly linked to an increased risk of cognitive decline. Studies from institutions like Harvard and the Mayo Clinic have shown that regular use of sedative hypnotics, especially in older adults, is associated with a higher likelihood of developing dementia and Alzheimer's disease. This isn't just a small statistical fluke. The correlation is strong enough that many neurologists recommend avoiding these drugs altogether in patients over 65. The mechanism behind this risk lies in how these drugs affect neurotransmitters and disrupt the architecture of natural sleep. Instead of allowing the brain to cycle through restorative stages like deep sleep and REM, many sleep aids suppress these phases, leading to poorer quality sleep overall, even if you don't wake up during the night. Over time, this interferes with memory consolidation, emotional processing, and the brain's ability to detoxify itself from daily metabolic waste, including beta-amyloid, the protein associated with Alzheimer's plaques. But the risks don't stop at the brain. Sleep aids also impair coordination, balance, and reaction time, significantly increasing the risk of falls, a leading cause of injury and death among older adults. Doctors are acutely aware of this risk, and many internal medicine specialists advise against prescribing these medications to elderly patients unless absolutely necessary. A nighttime fall can lead to hip fractures, head injuries, and a permanent loss of independence. That's why many physicians quietly rely on non-drug strategies to manage their own sleep disturbances. Cognitive behavioral therapy for insomnia, CBTI, which addresses the root psychological and behavioral causes of poor sleep, has been proven more effective than medication in numerous studies. Doctors often recommend, and use, techniques like keeping a strict sleep schedule, reducing screen time in the evening, using blackout curtains, and avoiding heavy meals or alcohol before bed. These methods may take time, but they foster real, restorative sleep without the cognitive hangover or risk of dependence. Speaking of dependence, that's another hidden trap of these medications. The body quickly builds a tolerance, requiring higher doses to achieve the same effect, and eventually, the brain may become unable to sleep without chemical assistance. This cycle creates both a physical and psychological reliance that can be incredibly difficult to break, especially for older adults who already face sleep changes due to natural aging. Withdrawal from these medications can lead to rebound insomnia that's worse than before, along with anxiety, irritability, and in severe cases, tremors or confusion. Many doctors have seen this pattern play out in their own patients, which is why they tread carefully and avoid starting that cycle for themselves. Even drugs marketed as natural sleep aids can carry risks. Melatonin, for instance, while generally safer, can interfere with the body's hormonal rhythms when used incorrectly or in high doses. And over-the-counter antihistamines like diphenhydramine, often found in nighttime painkillers, have potent anticholinergic effects, which are themselves associated with memory problems and increased dementia risk. Perhaps the most unsettling aspect of all is that many people taking sleep aids don't even realize how impaired they are. The sedation caused by these medications can linger into the next morning, dulling alertness, reducing mental sharpness, and contributing to daytime fatigue, the very symptoms they were meant to cure. For seniors who drive, manage medications, or live alone, this grogginess can be dangerous. Doctors, aware of these subtle impairments, typically choose alternative approaches for themselves. Mindfulness meditation, gentle evening yoga, magnesium supplementation, and blue light blocking glasses are all simple, low-risk methods many healthcare professionals use to help their own sleep hygiene. In medical circles, the quiet consensus is clear. Sleep aids are last resort, a temporary bridge during high-stress periods, not a lifestyle solution. If your sleep troubles have become chronic, it's far safer to investigate the underlying causes than to mask them with medication. Because in the long run, the cost to your brain and body may be far higher than a few nights of rest. Anticholinergic medications. A dementia risk few acknowledge. There's a silent class of drugs that lurk in many medicine cabinets, hidden behind familiar brand names but tied to alarming risks, especially for seniors. These are the anticholinergic medications, and while you may not recognize the term, chances are you've encountered them. They include common treatments for allergies, depression, bladder issues, and even colds. Drugs like diphenhydramine, Benadryl, amitriptyline, oxybutynin, and certain muscle relaxants fall into this category. They work by blocking acetylcholine, a key neurotransmitter involved in memory, learning, and muscle control. While this blockade can be helpful in treating symptoms like overactive bladder or seasonal allergies, it comes at a serious cost, particularly to brain health. That's why many doctors, particularly neurologists and geriatricians, avoid anticholinergic drugs altogether when it comes to their own health or that of their loved ones. The risks are simply too high, and the benefits too often overstated. Research has increasingly shown that chronic use of anticholinergic medications is linked to a significantly higher risk of cognitive decline and dementia. A landmark study published in JAMA Internal Medicine followed thousands of older adults over a decade and found that the cumulative use of strong anticholinergics was associated with a 54% higher risk of developing dementia. What's even more troubling is that these effects can begin subtly, with users experiencing increased forgetfulness, confusion, or difficulty concentrating long before a formal diagnosis. The reason lies in how acetylcholine operates in the brain. It's one of the most critical chemicals for short-term memory and attention, the very functions that begin to deteriorate in diseases like Alzheimer's. By blocking its action, anticholinergic medications essentially accelerate the aging of the brain. And while short-term use may seem harmless, studies have shown that even a few months of regular use can start to chip away at cognitive function. Doctors are especially wary of this class because of its insidious nature. These drugs don't cause a dramatic, immediate decline. The damage creeps in slowly, often masked as normal aging. A senior taking an over-the-counter sleep aid with diphenhydramine may begin to notice a bit more forgetfulness or grogginess in the morning. A few years later, that same person may be dealing with early-stage dementia, and neither they nor their doctors may connect the dots. Physicians who stay current with geriatric research often scrutinize their own medication lists to avoid this fate. They also warn against combining multiple anticholinergic drugs, which can amplify the effects and increase the risk of hospitalization for confusion, falls, or delirium, especially during acute illness or after surgery. Beyond cognitive impairment, anticholinergic medications also pose serious physical risks. By interfering with the nervous system, these drugs can cause blurred vision, dry mouth, constipation, urinary retention, and increased heart rate. For older adults, these side effects are not just annoying, they can be dangerous. A dry mouth may seem minor, but it raises the risk of tooth decay and infections. Constipation can lead to abdominal pain, appetite loss, or even bowel obstruction. And urinary retention can cause bladder infections, which, if untreated, may progress to more serious systemic infections. These seemingly small issues can quickly escalate, compromising an older adult's quality of life and independence. Physicians are often trained to look at these warning signs more holistically, connecting physical symptoms to the medications that may be quietly causing them. Because of this, many health professionals steer their personal choices toward safer alternatives. For allergy relief, they may choose second-generation antihistamines like loratadine or cetirizine, which have much less anticholinergic activity. For depression, they prefer SSRIs like sertraline or escitalopram, which don't block acetylcholine and have more favorable side effect profiles for seniors. When it comes to bladder issues, behavioral therapies, pelvic floor exercises, and newer medications with reduced anticholinergic properties are often recommended over drugs like oxybutynin. In their own lives, doctors weigh the long-term neurological risks far more heavily than short-term symptom relief. They understand that convenience today should never come at the cost of clarity tomorrow. One major problem, however, is that many anticholinergic medications are available over the counter. This creates a false sense of safety. Just because a drug doesn't require a prescription doesn't mean it's benign. In fact, many of the most commonly misused anticholinergic agents, like sleep aids or cold medicines, are used habitually by seniors without ever being flagged by a healthcare provider. Doctors who are educated in geriatric pharmacology take a very different approach for themselves. They read ingredient labels, they track cumulative anticholinergic burden, and they proactively remove or replace medications that could chip away at their mental sharpness. If your medicine cabinet contains more than one of these drugs, it might be time for a conversation with your doctor about alternatives. Because when it comes to protecting your brain, what you don't take could matter just as much as what you do. Fluoroquinolone antibiotics. A-class doctors avoid themselves. In moments of illness, antibiotics can seem like lifesavers, and often they are. But not all antibiotics are created equal, and one specific class has sparked serious concern among healthcare professionals. Fluoroquinolones. Drugs like ciprofloxacin, Cipro, levofloxacin, Levaquin, and moxifloxacin, Avelox, fall under this category. Once hailed as broad-spectrum heroes capable of tackling everything from urinary tract infections to pneumonia, they've now earned a reputation that makes many doctors think twice before prescribing, especially for themselves or their families. The reason is unsettling. Despite their power, fluoroquinolones carry a long list of potential side effects that are not only severe but often permanent. And that's not just a rare fluke. The risks are significant enough that the FDA has issued multiple black box warnings, the strongest alert a drug can carry, about their use. One of the most alarming side effects linked to fluoroquinolones is tendon rupture. This isn't a hypothetical concern. Seniors, especially those over 60, are particularly at risk, with the Achilles tendon being the most frequently affected. A sudden snap can lead to months of immobility, surgical repair, and prolonged physical therapy. Worse still, tendon damage can begin as subtle pain or stiffness and escalate into a full rupture without warning. That's why orthopedic surgeons often advise patients, and avoid themselves, using these drugs for routine infections. But the danger goes deeper. Fluoroquinolones have also been associated with a range of serious nervous system complications. This includes peripheral neuropathy, where patients experience burning, tingling, or shooting pain in their limbs. These symptoms can emerge within days of starting the drug and, for some, may never fully go away. Neurologists are particularly wary of this side effect, which has led many to remove fluoroquinolones from their personal treatment options except in cases of life-threatening infections. Then there are the psychiatric effects. While less widely known, fluoroquinolones have been linked to confusion, hallucinations, insomnia, anxiety, and even suicidal thoughts. Effects that can occur even in individuals with no prior history of mental health issues. Older adults are especially vulnerable to these changes due to natural shifts in brain chemistry and increased sensitivity to medications. The mechanism behind this toxicity likely involves disruptions in GABA receptors in the central nervous system, but the research is still evolving. What's clear, however, is that enough cases have surfaced to trigger caution among healthcare professionals. Many physicians quietly steer their loved ones away from these medications unless absolutely no alternatives exist. And that's an important detail. There usually are alternatives. For urinary tract infections, antibiotics like nitrofurantoin or trimethoprim sulfamethoxazole are often effective. For respiratory infections, amoxicillin or doxycycline can be appropriate in many cases. Doctors well versed in antimicrobial stewardship reserve fluoroquinolones as a last resort, not a first-line choice, a standard not always followed in general practice. Another disturbing aspect of fluoroquinolones is their impact on connective tissue beyond the tendons. Some studies suggest a possible link to aortic aneurysms and dissections, which are life-threatening conditions involving the body's largest blood vessel. While more research is needed, the FDA has already acknowledged this potential risk, especially in patients with a history of vascular disease. Cardiologists and vascular specialists have voiced concern about prescribing these drugs to high-risk populations, and many have removed them from their own protocols. This careful avoidance underscores a broader trend. Physicians who understand the molecular effects of fluoroquinolines tend to take a far more cautious approach than what's commonly practiced in urgent care or family clinics. Part of the issue is that many doctors outside infectious disease or pharmacology specialties aren't fully aware of these newer warnings or the alternative treatments available. Perhaps what makes fluoroquinolines even more dangerous is how casually they're prescribed. In many cases, patients receive these powerful drugs for mild infections that would likely resolve on their own or respond to safer antibiotics. This casual use increases the chances of unnecessary harm. Doctors who stay current with the research understand the importance of risk-benefit analysis, and they don't gamble with their own long-term health. They know that while fluoroquinolines may be effective, the price can be steep, sometimes permanently disabling. That's why many healthcare providers advocate for better patient education and insist that these medications only be used when absolutely necessary, and only for infections where other drugs have failed or are contraindicated. In an age where bacterial resistance is growing and antibiotic choices are becoming more complex, fluoroquinolines remain a powerful tool, but one with sharp edges. The professionals who work daily with these medications know better than anyone that power should be matched with precision. And for that reason, they often say no to fluoroquinolines for themselves, knowing that a safer path is almost always within reach. The safer alternatives doctors actually prefer, and why you should too. When doctors decline medications for themselves, it's not because they're anti-science, it's because they know that medicine, when used without precision, can often cause more harm than good. What many people don't realize is that behind closed doors, healthcare professionals often take a vastly different approach to their own treatment plans. Rather than immediately reaching for a prescription bottle, they turn to strategies and alternatives rooted in prevention, physiology, and long-term resilience. These alternatives are not only safer but often more effective in the long run, especially for seniors who face compounding health risks with every added medication. In fact, most doctors prioritize lifestyle medicine as their first line of defense, a philosophy that emphasizes nutrition, movement, stress reduction, sleep hygiene, and targeted supplementation. The result isn't just fewer side effects, it's better health outcomes across the board. For example, in place of proton pump inhibitors, many physicians favor digestive aids that support natural gut function. Digestive enzymes, deglycyrrhizonated licorice, DGL, and even basic dietary changes, like reducing late-night meals, avoiding acidic or spicy foods, and eating smaller, more frequent meals, are often enough to manage mild reflux. Elevating the head of the bed and chewing slowly are simple, no-cost techniques that are frequently overlooked in traditional care but well utilized by doctors managing their own gastrointestinal symptoms. When it comes to statins, many doctors explore functional markers like inflammation, insulin resistance, and oxidative stress before committing to long-term drug therapy. They may increase their intake of omega-3 fatty acids from fatty fish or algae supplements, take magnesium and CoQ10 to support heart health, and regularly check advanced lipid panels that assess more than just LDL cholesterol. They know that cardiovascular risk is complex, and that a pill is never a substitute for anti-inflammatory living. For sleep, doctors are even more cautious. They understand that sedation is not the same as rest, and that the real solution to insomnia lies in sleep education, not chemicals. Cognitive behavioral therapy for insomnia, CBTI, is often their go-to, and many invest in weighted blankets, white noise machines, or blackout curtains to fine-tune their sleep environment. They also monitor caffeine and alcohol intake carefully, knowing both can disrupt circadian rhythms. For relaxation, techniques like diaphragmatic breathing, progressive muscle relaxation, or short guided meditations are used far more often than pills. If supplements are used, they're selected carefully, such as low-dose melatonin timed with sunset, magnesium glycinate, or calming herbs like lemon balm and passion flower, each chosen for its gentle support without risk of dependency or next-day grogginess. In the case of anticholinergic medications, especially those used for overactive bladder or allergies, doctors tend to choose newer generation alternatives that have minimal impact on cognition. They may also incorporate bladder training exercises, pelvic floor strengthening, and reduce dietary triggers like caffeine or artificial sweeteners, strategies that require more effort but carry far fewer risks. For allergy symptoms, they lean toward non-sedating antihistamines such as loratadine or fexofenadine. And if depression is a factor, they typically choose SSRIs or SNRIs over older tricyclic medications, which are known for their heavy anticholinergic load. The emphasis is always on maintaining mental sharpness, avoiding sedation, and keeping the total anticholinergic burden as close to zero as possible, something few patients are ever taught to do but which many physicians track meticulously. When it comes to avoiding fluoroquinolone antibiotics, doctors know to ask for sensitivity results from cultures when treating infections, rather than guessing or relying on broad-spectrum drugs. They also emphasize prevention, drinking enough water to prevent UTIs, washing hands regularly, and not demanding antibiotics for viral infections. In their own care, they're quick to explore first-line antibiotics with fewer side effects, and often educate their family members to do the same. They advocate for probiotics during and after any antibiotic course to restore gut flora. Knowing this step can make a world of difference in recovery. Their philosophy: preserve the body's systems as much as possible, and use the nuclear option only when there's no better choice. The unifying principle behind all these alternatives is intentionality. Doctors weigh benefits against risks in a way that few patients are taught to do. They focus on maintaining the body's internal balance, protecting the gut, the brain, the heart, and the nervous system, not just treating symptoms. They recognize that medications are tools, not magic bullets, and that every decision has a ripple effect. What they choose for themselves reflects a deeper understanding of long-term health and a fierce commitment to avoiding preventable damage. For seniors, this mindset is invaluable. Because at a stage of life when resilience begins to wane, every choice matters more. The good news is that the same strategies doctors use for themselves are available to you. And by adopting this thoughtful, cautious, and proactive approach to health, you can avoid unnecessary risks, preserve your independence, and feel better in ways no pill could ever promise.